May I invite the first speaker, Dr. Shaleen Agarwal, who is the Director of Liver Transplant and HPB Surgery from M.I.C.E Super Specialty. And he has to speak to us about strategies for ABOi incompatible liver transplant. So, Dr. Shaleen, please share your screen and start your talk.
Thank you very much, Dr. Sujoy. So at the outset, I would like to thank all the chairpersons, Dr. Sujoy, Dr. Nimesh, Dr. Rav, and Dr. Puri for giving me this opportunity. And of course, my thanks to Dr. Sanjeev Sehgal, who's the organizing chairman of this wonderful meeting. So my brief today is to talk about strategies for ABOi liver transplantation. And I think it's an honor to prepare ground for the next talk by celebrated Professor Igawa, who has actually, and I would be sharing a lot of material from what he has researched and what has come into practice and clinical vogue for ABOi and ABO incompatible liver transplant all around the world. So I'll just start with a little background. Way back in the late 70s, uh, the concept of that liver is a privileged organ and rejection in liver transplantation is less as compared to other transplants, particularly kidney transplants. That concept was given by Professor Stasel, and that was based on his report of 11 cases of pediatric ABO incompatible liver transplant. And none of the protocols that have been laid down over the last 10 to 15 years were followed or were available at that point of time. And still, out of 11, 8 of his patients survived more than 2 months, and acute rejection was seen in only 2 of these. So there's initially in those years, there was a lot of enthusiasm about ABO incompatible liver transplant, and the actual mechanism of rejection, especially antibody mediated rejection, was not clearly understood at that point of time. However, in the subsequent decades of 80s and 90s, when other people tried to follow Professor Stasel's example, the results were totally dismal. And the reason probably being that most of these transplants in the subsequent decades were in the adults, and the graft survival was to the tune of less than 30% at 1 year. The strategies such as increasing the level of immunosuppression and the use of ATG did not help, and therefore the concept of ABO incompatible liver transplantation went into cold storage for almost 8 to 10 years. So the main challenge in ABO incompatible liver transplant is acute rejection, particularly what we call the antibody mediated rejection, and it was the Achilles heel of this kind of or this type of liver transplant. How does it manifest? Basically, it is a kind of single organ diffuse intravascular coagulation. That has what been that term has been introduced in literature, and it consists of widespread hemorrhagic necrosis on explant pathology, as well as biliary necrosis with diffuse intrahepatic biliary strictures. So before we embark on to strategize about a successful ABO incompatible liver transplant, we should know about the underlying mechanism of graft injury. So as we all know that B lymphocytes play a pivotal role in organizing this or initiating this antibody mediated rejection. And along with them, we have the memory B cells and the plasma cells, which take part in initiating the antibody mediated rejection. ABO blood group antigens are expressed widely in the liver, including the vascular endothelium, the biliary epithelium, and the RBCs also carry these antigens. So the antibodies to the foreign blood group in the graft bind to these, that is the recipient antibodies to the foreign blood group antigens in the graft bind to these antigens. That leads to complement activation and formation of what we call is known as the membrane attack complex. This membrane attack complex causes injury to the vascular and the biliary endothelium epithelium respectively, leading to capillary necrosis of these endothelia and epithelia respectively. When there's a large scale vascular thrombosis, it manifests as hepatic necrosis and acute graft loss. While if there is a limited, slowly progressive microvascular thrombosis, it manifests in a more, I would say, benign condition, that is a diffuse intrahepatic biliary strictures. So this is how the AMR develops in ABO incompatible liver transplant. And this is just a cartoon showing what I've just said, that the antibodies bind to the blood group antigens that are carried on the vascular endothelium, leading to complement activation, followed by formation of the membrane attack complex, which in turn results in injury to the endothelium, cell apoptosis and lysis, and finally thrombosis of the microvasculature leading to graft damage. So what are the goals in ABO incompatible liver transplant? So the main goal is prevention of rejection, and in particular antibody mediated rejection to the foreign blood group or the unmatched blood group antigens in the graft. So this can be achieved in two ways. One is you remove the circulating anti-ABO antibodies in the recipient before you put in the graft with an unmatched blood group. And secondly, you prevent or reduce the production of these antibodies in the subsequent post-transplant period. So one is that you lay a ground or you create a soil in the recipient where the unmatched blood group graft can be accepted. And then you take care that these antibodies, once you have removed them, are not again, they do not develop again or produced again to cause graft injury. So now we come to the strategies that have been adopted and are now universally used to achieve these two goals. One is plasmapheresis, that is, this is the mechanical removal of the circulating antibodies. As a similar technique, immunoadsorption, and the variants of these techniques, that is the apheretic techniques. Then you have the pharmacological means, that is injection rituximab, which is basically an anti-CD20 monoclonal antibody. CD20 is the receptor that is carried on the B cells. Then other modalities that have been used to prevent or treat AMR are use of IVIG, SNECTMI, local graft portal, or the intraarterial infusion therapies. So I'll devote some time to each of these strategies in the next 7 to 8 minutes that are remaining. First and foremost is apheresis. The goal is removal of circulating ABO antibodies. This is a very mechanical procedure. The target for antibodies that have been laid down by various centers varies from as low as 1:8 to as high as 1:64. So each center has put down its own protocol as per the antibody titers at which they are comfortable taking up a patient for ABO incompatible liver transplant. And the methods for achieving these antibody titers are plasmapheresis, immunoadsorption, cascade plasmapheresis, and the double filtration type of plasmapheresis. Plasmapheresis removes the antibody along with the recipient plasma, which is in turn replaced by donor plasma from the random donor plasma from the blood bank, as well as albumin. And the percentage of each of these two therapies, or that is plasma and albumin, varies from center to center. We have been using it from 50 to 70% plasma. These days we use 50% plasma and 50% albumin. And the plasma which has been removed from the recipient's own plasma is discarded. That is the main drawback of this technique, plasmapheresis, because along with the plasma, a lot of coagulation factors and the useful protective antibodies are lost, putting, at least theoretically, the the potential recipient at risk for infections and bleeding during surgery, increased bleeding during surgery. So an alternative to plasmapheresis is the technique of immunoadsorption, where you have specific antibody columns and the plasma is filtered through these columns, and there's only selective removal of the blood group antibodies, and the rest of the plasma is put back into the patient's circulation. So the advantages of immunoadsorption are basically, since the large volume of plasma is not being lost or discarded, the hemodynamic stability is better maintained, and there are no adverse reactions related to infusion of foreign plasma. And this is again a pictorial representation of how the two techniques differ. In plasmapheresis, basically, there is a separation of blood cells from the plasma, and you discard this plasma, as a result of which the circulating ABO antibodies are removed, and you replace it with the fresh plasma and albumin. While in immunoadsorption, you are just passing the separated plasma through an antibody column, and where these antibodies are removed, and the plasma is the same plasma, that is the recipient's plasma, is put back into the patient's circulation, leading to better hemodynamic stability and lesser risk of adverse reactions related to foreign plasma. Coming to rituximab, basically rituximab has been the game changer in this entire picture of ABO incompatible transplantation, whether it's liver, kidney. First introduced in 2003, and since then uh, there's been resurgence of interest in ABOi compatible liver transplant because of dramatic improvement in the outcomes. So what does the rituximab do? It suppresses the B lymphocytes. However, it does not act on the plasma cells and the memory B cells. And that is why, despite complete suppression of CD20 positive B lymphocytes by rituximab, you can still have rise in antibody titers, as we all have seen. Basically, it's a prophylactic therapy and results in a kind of chemical splenectomy. Why chemical splenectomy? Because spleen is the main storage organ for these B cells, including the plasma cells as well as the memory B cells. Onset of action of rituximab is within 2 to 3 days, and it lasts up to 66 months, maybe more. So what should be the timing and dose of rituximab? It has not yet been standardized, but usually, as per what Dr. Igawa has also recommended in his after his research, is that it should be at least 1 week prior to the planned transplant. And I think most of the centers, including ours, follow a 2 week waiting period. That is time difference between the administration of rituximab and the transplant. Again, the dosage which has been recommended by the Japanese Society is 375 milligram per meter square. And in adults, a dose of less than 300 milligram is usually considered inadequate. We use a standard dose of 350 milligram, and this has come by hit and trial, and this is not standard. Different centers have been using different doses. But what is clear is that single dose is adequate. Multiple doses does not decrease the level of that is suppression of B cells. Even one dose is good enough, but it in turn leads to increased incidence of fungal and CMV infections in the post-transplant period. Coming to splenectomy, as I just said that spleen is a storage area for the B cells, plasma cells, and the memory B cells. Therefore, splenectomy was widely adopted in the pre-rituximab era and still being used by some centers selectively. But the main disadvantages of splenectomy during the liver transplant are that technically removing a hugely enlarged spleen along with collaterals is not an easy task. It is easier said than done. It may be associated with massive bleed and even patient loss as a result of bleeding has been reported. Even if you do you are successful with the splenectomy, there's an increased risk of postoperative infections, portal vein thrombosis, and pancreatic fistula. And there has been study published which have compared levels of AMR in splenectomized versus non-splenectomized patients, and no difference or no impact of splenectomy was found on the incidence of AMR. And now with the introduction of rituximab, operative splenectomy has been replaced by chemical splenectomy. However, splenectomy still have a role in emergency liver transplant for ALF. There are some reports to that effect, but still the role of splenectomy has reduced very much. It has gone into the background. It's not practiced any longer. Coming next to IVIG, it's basically the function is complex, not clearly understood. All we know is that it has an immunomodulatory function. It leads to B cell apoptosis and suppression of B cells. It inhibits complement-mediated injury by reducing the generation of M.I.C.E. And it is a part of desensitization protocols in some centers. But again, it's not favored widely. May have a role in the treatment of antibody-mediated rejection, again doubtful. And Japanese multi-center study did not show any benefit of using of IVIG. Local graft infusion therapy, it involves the placement of catheter in the graft portal vein and then infusion of pharmacological agents such as methylprednisolone, prostaglandin, and gabexate mesylate. Mechanism of action is multifarious, including anti-inflammatory, vasodilatation, and prevention of platelet aggregation. However, catheter-related complications outweigh the benefits. That includes thrombosis, vessel rupture, and abdominal bleed, including graft loss. Therefore, it's no longer used in elective liver transplant, but may have some role in emergency LT in ALF, as has been reported from some Japanese centers. So coming to the desensitization protocols, all the protocols that are used currently are modifications of the Japanese protocol, and it's been widely successful. The currently reported AMR rates are less than 60% with 3-year graft survival more than 80%. So splenectomy is no longer used. Rituximab is given 2 weeks in advance prior to transplant, and standard triple dose immunosuppression is used. In the Japanese protocol, they start tacrolimus and MMF 7 days prior to transplant. but that has been modified by various centers, including ours. ABOi compatible liver transplant in fulminant hepatic failure, there's very limited experience, no standard desensitization protocol. Use of rituximab immediately pre-LT and post-reperfusion has been reported. However, plasma is the mainstay of methodology for reducing the antibody titers. Some centers have used splenectomy and local graft infusion. Monitoring for AMR, again, there's no single predictor. Combination of methods. The usually used predictors are rise in antibody titers, derangement of liver enzymes and bilirubin, reduction in portal flow on serial Doppler that we have observed. And liver biopsy is not the gold standard. C4d positivity, as has been reported in kidney transplant, may not be true for liver transplant. Treatment of AMR consists of prevention is the best part, and the strategies that have been used are plasmapheresis, IVIG, steroid boluses, and proteasome inhibitor. Bortezomib has also been reported in the treatment of AMR. Now, briefly, since my time is up, I'll go through the protocol that we have been using and developed over the years. So prior to desensitization therapy, we do the antibody titers and the CD19 and 20 percentages. We use a single dose of rituximab, 350 milligram in adults, 2 weeks prior to LT. The apheretic technique that we prefer is plasmapheresis. Immunoadsorption is used for refractory cases, and a combination is used when the patients have very high baseline titers. And we first mop up the antibodies, remove the major bulk with plasmapheresis, and then mop up with immunoadsorption. The target for antibody titers before transplant is 1:16. Post-LT monitoring for AMR is on the basis of twice daily antibody titers for 2 weeks. Doppler studies, again morning, evening for 2 weeks, and daily blood counts and biochemistry, routine biochemistry. We use the standard 3-drug immunosuppression from day one. Don't start it pre-LT. Anticoagulation, and CMV prophylaxis are used, and routine liver biopsy is not a part of our protocol for monitoring for AMR. So this is our protocol, desensitization protocol that we use, very similar to the Japanese, except for that we don't start MMF and tacrolimus 7 days prior to transplant. We start on POD1. Our protocol for managing suspected AMR is we use plasmapheresis, and the indications for plasmapheresis are 2 serial rise in antibody titers even with normal LFT, or if there is a rise in bilirubin and enzymes along with rise in antibody titers, or there's a derangement of LFT and reduction in portal flow. Sometimes we have used plasmapheresis even when the titers are normal. Steroid boluses are used frequently when there is derangement of LFT and reduction in portal flow despite normal antibody titers. And this we have observed in last several of our cases that we have done is that it happens during the end of the 5th to 7th day of post-transplant that we see a rise in derangement of LFTs and reduction in portal flow, and steroid boluses have been very helpful. IVIG is not a part of our protocol. And just I'll finish with last few slides to share our experience of ABO in compatible liver transplant. Till date, we have done 74. The first was done in 2014. And with increasing experience, our results have improved, and so have the numbers. So we have done all age groups. 11 patients were infants. And we have done fairly sick patients, with all patients being CTPC, MELD score of median of 20. We have done ABOi compatible NCC patients. The most common blood group combinations were B to O or A to O. And the range of baseline titers has varied widely from 1:2 to 1:2048. Desensitization is the mainstays rituximab and plasmapheresis, as is shown here. The median number of sessions used was 2, ranging from 1 to 11. All were LDLTs, majority of them being modified right lobe grafts. And coming to the outcomes, AMR, again suspected because we didn't prove it with biopsy, was seen in 23 out of the 74 patients. 8 patients had early allograft dysfunction, and this is following the definition when you exclude all other causes, technical as well as sepsis, as the cause of early allograft dysfunction. Bile leak occurred in 6. Sepsis was seen in 11 patients. And post LT in hospital mortality was in gross appears high. Total 18 deaths have been recorded out of the 74. But when we count the deaths that could be attributed to early allograft dysfunction or sepsis, there were 13.5%, which is not much higher than for the non-ABO or the ABO compatible group. So I think with the increasing experience, the results have improved, and the results of ABO incompatible are not very different from compatible liver transplant. And this is my last slide, just to summarize that strategies for ABO incompatible liver transplant are continuously evolving. Multiple desensitization protocols have been published, but for all these protocols, rituximab and apheresis are the mainstay. Invasive interventions like splenectomy and local graft infusion therapy are no longer preferred. And for a successful outcome, close monitoring is the key. That is, you monitor in the form of daily antibody titers, LFTs, Doppler monitoring during the early post-op period. And if you follow all this, as has been our experience, the results are bound to improve and uh, equal as with ABO compatible liver transplant. Thank you for your kind hearing. Thank you very much.
Thanks, Shaleen, for giving a very conceptual talk and also sharing your results. If there are any questions, maybe we can take one or two before we move on to the next talk.